Welcome to the Evelyn Y. Davis Studios at the National Press Foundation. Funding for today's webinar was provided by Bayer. We've heard a lot this year about measles. Nearly 150 U.S. cases, 17 states, plus D.C. What's happening and why? What else should we be worried about? We'll get to all of it right now. The National Press Foundation is a nonprofit dedicated to helping journalists cover complex topics with depth and accuracy. Our mission includes journalists around the U.S. and around the world. Welcome back. I'm Linda Topping-Streitfeld, Director of Programs at the National Press Foundation. Joining me in the Evelyn Y. Davis Studios, Dr. Anne Schuchat, Director of the National Center for Immunization and Respiratory Diseases at the CDC and a Rear Admiral in the U.S. Public Health Service. Welcome.
Thank you.
If you're watching live, we want to take your questions. You can type them into the chat window under the webinar screen, either log in or just sign in as a guest, and we'll get to as many as we have time for. First, Dr. Schuchat, thank you so much for being here. I know you've come with some slides. Let's get right to them.
Absolutely. Thank you so much, Linda, for the chance to talk with folks today. You know, measles has been getting a lot of attention this year. It seems like everyone is talking about it, making the headlines, being a topic of congressional hearings, and I think today is a chance for us to get the facts out. Well, the big story has been a large outbreak associated with the Disney parks in California, and as of the 20th of February, we're up to 133 people who have developed measles with a direct or indirect link to that outbreak. The outbreak is occurring in California and in 6 other states, and it gives us a chance to recognize that having this much measles this early in the year is actually unusual. But I think it's important to put this outbreak in perspective because it is night and day today compared to more than 50 years ago before we had the measles vaccine. In 1963, the first measles vaccine was licensed, and before that time, about 450,000 Americans developed measles each year. Since 1989 to 91, a second resurgence occurred that 3 years where we saw 55,000 cases of measles in the 3-year period. They were primarily occurring in children who were toddlers who had never gotten the measles vaccine. That resurgence in the late 80s, early 90s was due to missed opportunities to vaccinate. And we got this great program after that, the Vaccines for Children program, which provided access to vaccines for uninsured children, really providing huge opportunity to reach the marginalized kids. We saw great progress after that. In the year 2000, we declared measles eliminated from the United States. People wonder, what does elimination mean? Well, elimination means that there is not continuous circulation of the measles virus for 12 months or more. How did we get to that elimination status? Very high 2-dose coverage with the vaccine, high quality surveillance and response, and improved control in the Americas, because before 2000 we were seeing importations from the Americas. So we've really seen huge progress up through 2000. Well, what's happened since then? It turns out that we are seeing a resurgence. And so when we look back to the year 2000 and onward, the year 2014 was a record. We had more cases in 2014 than we'd had in more than 20 years. This was a wake-up call and something that we're continuing to follow this year. In this slide you can see in red importations, and you can see that in most years since 2001 there's not much yellow, it's mostly red. The imported case occurs and there's just 1 or 2 cases that occur associated with those imported cases. But in a few years, 2008, 2011, 13, and 14, we see a lot more yellow. That is, the virus comes in and instead of stopping, it spreads. It's spreading because it's finding communities or micro-communities where there are many unvaccinated people. Each of the circumstances of that spread differ. Sometimes it's religious communities, sometimes it's wealthy communities of people who are exempting from vaccine, but what we're really focusing on now is why is the virus spreading when it comes in. There's still measles all around the world, and we need to have very high coverage to protect ourselves as a community, as a country, from that spread. When we look at the first decade following elimination, we had a median of 60 cases a year and about 33 importations a year. Measles can be serious even in the U.S., and we saw about a quarter of those cases required hospitalization, and there were 2 deaths in about 1,000 cases. So fortunately, not a lot of people dying from measles here in the U.S., but it can be fatal. The majority of cases we were seeing were in unvaccinated people. And we had a handful of outbreaks a year throughout the country. Since 2011, we've seen a change. We're having about twice as many cases a year, 2 or 3 times as many cases a year, with the median of 205, and we're seeing more importations. Last year, we had about 60 imported cases, and those cases are spreading more widely. 2014 was outside previous years. We had 644 cases, much greater than we'd seen since elimination. And the circumstances in 2014 were really linked to a very large outbreak that occurred in the Amish population in Ohio. So while we had a lot of importations, most of the importations didn't go very far, but 3/4 of the U.S. residents that got measles last year had been unvaccinated. Almost 80% were unvaccinated because of personal beliefs. A small percentage were unvaccinated because they were traveling and they didn't realize they needed to get the vaccine early in the case of young children. And then we had about 8% that developed measles because they were too young to be vaccinated. They were under 12 months, which is the routine age for vaccination in people who aren't going to be traveling.
May I clarify for a minute?
Sure.
You mentioned a certain percentage of cases among people who were unvaccinated, which leads me to believe there were some cases among people who had been vaccinated. How do you explain that?
That's right. The measles vaccine is very effective. 1 dose is about 94% effective, and 2 doses is 97% effective. But that means 3% of people who are immunized, even getting the 2 doses, won't respond. They don't make antibodies in response to the vaccine. That small vaccine failure group is one of the reasons that we need very high vaccination. Some people can't be vaccinated because they're babies and they're too young for routine vaccination. Some people can't be vaccinated because they're immunosuppressed. Right. They have leukemia, they're on chemotherapy, they're taking prednisone or other steroid medication. They can't be vaccinated because it's a live vaccine. It's a weakened virus, but it's live. And so we need really high vaccination for those people who won't respond to the vaccine or aren't able to get the vaccine themselves. Fortunately, in the U.S., we've had really high coverage, and we've been able to protect those vulnerable people, the babies and the others, through the high coverage. But we're at risk for resurgence and for spread of the virus when we have pockets that are not well vaccinated. The people who aren't vaccinated are at risk, and the people who can't be vaccinated are also at risk. We see that this year, since January, we've had a record number of vaccines for this time this year. As of February 20th, we actually have 154 cases, a bit higher than last week. We've just posted our new numbers up on CDC's website, cdc.gov. Those 154 cases are occurring in 17 states around the country. A lot of them are associated with the outbreak in California from the Disney park, but we have other cases as well. We've had importations from 7 different visitors, travelers, people traveling abroad bringing the virus back, people visiting a variety of countries. So the situation in the U.S. is we're continuing to see imports, and occasionally we're seeing spread from those importations. A lot of spread from the Disney parks, and some spread from virus imported into other communities. This year, we've seen measles spread in a number of circumstances, and every single case of measles requires our public health frontline workers to follow up actively. They've needed to follow up measles that's come into hospitals and emergency rooms, measles that's come into child care centers, measles in households, as well as measles on airplanes. And so every single case is a possible outbreak, and we need our frontline public health responding very aggressively. That's one of the reasons we've had such good control of this disease, but we can't take it for granted. And these individual cases get an active follow-up. All the contacts that might be immune or might not be immune need to be sorted out. So it's a huge effort. So far in 2015, most of the cases we're seeing are in unvaccinated people or people who don't know whether they were vaccinated or not. We've had actually importations from Azerbaijan, Indonesia, Qatar, Pakistan, Dubai, India, and Singapore, Indonesia. Not places that you're going every year, but a couple years ago we had lots of importations from France, lots of importations from Switzerland. Measles is still circulating in many parts of the world. This year there are 3 different genotypes that we've found, and we have outbreaks, as I mentioned, associated with the amusement park, another outbreak associated with the child care center, and our states are actively following up cases in other states to figure out whether there are going to be more outbreaks or not.
I want to ask you for a minute about genotypes. The measles vaccine is protective against all the genotypes?
That's right. Although the measles virus can have a lot of different genetic signatures, the vaccine crosses all of them. The measles vaccine is one of the best vaccines we have, really high efficacy. It has a good safety track record. Of course, it's a live viral vaccine, so you have to be careful who gets it. But it works against all the types out there. We do the genotyping, though, to understand the epidemiology. Sometimes a case occurs in someone who has no travel history. They haven't gotten contact with someone who has been traveling, but the viral signature, that genotype, is a clue to us about where the strain originated. And so worldwide, we're seeing fewer and fewer genotypes as other parts of the world get better control of measles, but we still are seeing a number. And this year, the 3 types that we're seeing are actually kind of common. The B3 type is the type that was causing a huge outbreak in the Philippines a couple years ago that has continued, but that genotype is actually circulating in 14 different countries. So just knowing it's B3 doesn't tell us where it came from. And the D8 and D9 are circulating in Asia at this point. So we do the genotyping to try to understand where has the virus come from. Of course, other regions of the world are working really actively to reduce measles and to raise their coverage. We don't see importations really from the Americas anymore because the Americas have really done a good job of raising vaccine coverage. The outbreaks that we see turn out to be quite expensive. As I mentioned, every single individual case needs an active follow-up, and when you get cases occurring in hospitals or workplaces or schools, the follow-up is quite extensive. So this slide just summarizes 6 different outbreaks and the costs that they led to, and you can see that particular public health costs could reach over $1 million. So even for a single case in Iowa, the follow-up was greater than $100,000. A really active follow-up. It's important, though, because this effort keeps us from having measles gain a foothold again.
And who pays for that follow-up?
Right. The follow-up is generally carried out through the public health sector. Hospitals or office pediatric practices, for instance, will do follow-up in terms of, cleaning up the facility and identifying the patients that had been in the office. But the local or state health department is really on tap to follow these people up. Our local state health departments have been really busy the past year. They've been following up people who travel in from Ebola-affected countries. They're dealing with outbreaks of other conditions as well. That's really the fire department for these contagious diseases. And they don't get a lot of glory. Often we don't even think about them because we have such good control of diseases, but we have good control because those folks are working day and night, honestly, following up individuals, understanding where did you go, who might have been in contact, have those people been vaccinated, or are some of them vulnerable. If we find contacts exposed to a measles case within a short period of time, they can benefit from vaccine. If we find them in a longer period of time, they may benefit from immune globulin. And so that active follow-up is to try to protect the most vulnerable. If the window for that aggressive prophylaxis is over, we still want to follow them up and tell them to stay away from other people during that period where they may still be incubating the disease. And so that's why sometimes the babies have to stay away from everybody else, or a child who's unvaccinated can't go back to school until that incubation period is over, so that they don't infect, the vulnerable people in the school who wouldn't have been able to be vaccinated. So it's a lot of work to sustain elimination, right. And we'll be better off when the rest of the regions of the world have fully eliminated measles.
Right. I think it's very interesting for journalists to note that it is the local health department who bears much of the expense when there's an outbreak in a particular community.
Yeah, I think that's a great comment, and I would say that I know it's frustrating to journalists in the middle of an outbreak to not be able to get the local health department on the phone, and that's because they're running around trying to deal with the cases. Our local health departments have not got a lot of resources, and so exactly. The ability to keep on top of the disease control as well as keeping people informed can be difficult. I know that can be frustrating when you really want the latest numbers, but as I'll say in a moment, the numbers aren't really the full story with measles. So when we think about how is it that we maintain measles elimination, we need really high coverage with 2 doses of MMR. We need a high-quality surveillance system and a rapid identification of possible cases. We need to have aggressive outbreak control measures. We need good labs that are able to test for the virus. And of course, measles has become so rare that labs aren't used to testing for this virus. We've set up special reference labs for our vaccine-preventable diseases that can help with that now. And of course, a real key to maintaining elimination is to think beyond our own borders, because measles is spreading around the world. Turns out there are about 20 million cases around the world each year, and measles is literally an airplane ride away. We want high vaccination coverage all throughout the world, and we want people traveling abroad to remember that measles may be circulating. Whether you're going to a developed country or a developing country, you can pick up measles if you're not fully vaccinated. So if you're traveling with a young child, you especially need to pay attention to this. Our routine measles vaccine recommendations focus on children. We recommend 2 doses for everybody. 2 doses are routinely given at the 12 to 15 month of age and before kindergarten at 4 to 6 years. But you can get that second dose as earlier, as long as it's 28 days after the first. Adults without evidence of measles immunity also may need a measles vaccination. We recommend documentation of 2 doses for certain people who are at higher risk. Healthcare people, because they may be coming in contact with someone with measles. People who are entering college, because they may be entering a situation where the virus can spread more easily. And travelers, because they easily could be traveling to a part of the world where measles is still circulating. For other adults, it's important to have demonstrated that you've had at least 1 dose of vaccine, or that you were born before 1957, because that was before the vaccine was available, and virtually almost everybody born before 1957 actually developed measles themselves and would have lifelong immunity. We also have special recommendations for travelers, and this is really important for parents to know. We routinely vaccinate babies at age 12 months, but it turns out that if you're going overseas and your child is at least 6 months of age, we want them to get a vaccine dose before they travel, because they're going to be vulnerable. They're still going to need 2 doses when they come back. So between 12 and after they hit 12 months, they'll need to get really start their real series, but we want them to be protected during that 6 to 11 month period. Well, how are we doing as a country? It turns out that generally we're doing pretty well, with 92% of toddlers having gotten at least 1 dose, and most states having 90% or more of children having gotten vaccinated before kindergarten entry. But there are a number of states with less than 90% MMR coverage among their entering kindergartners. And of course now we're seeing a number of states where more than 4% of children entering kindergarten exempt from 1 or more vaccines. We think that's a setup for the virus to spread in those states, and in some of these states, schools, individual schools, can have even 20% of children exempting from vaccine. That is a real dangerous situation. We think it's very important for parents to know that measles is still around and the vaccine is still needed. States can have different laws about requirements for vaccines. The CDC doesn't set the school requirements. The states and cities set those. And all states provide medical exemptions because we don't want a child with leukemia getting an MMR vaccine. But some states allow religious exemptions and some states allow personal belief exemptions. And some states really blur the border between a religious and a personal belief exemption. Many states have had very loose exemption requirements, and we think tightening up the exemption requirements is important to protect children in our communities. I think it's really critical that it should be easier to get a vaccine than to exempt from vaccines. And we've seen that when it becomes harder to get exemptions, fewer people actually opt for them. Many times it's an exemption of convenience. It's not related to a very strongly held belief. So we would like to see stronger rules around exemptions to protect the individual children and to protect the communities as well.
Well, that is a good segue to a question that has just come in. Becky is asking about individuals with a particular gene mutation called MTHFR, which she believes affects a significant proportion of the population, and there are technical reasons she indicates that people with that mutation might be vulnerable to toxicity from a vaccine. Are you familiar with that?
Well, let me say that it's very important that we have a vaccine safety system and that we review everything we know about the vaccine's benefits and the vaccine's harms regularly. Mm-hmm. So the CDC runs an advisory committee on immunization practices that reviews the latest evidence annually and updates the vaccine schedule. And for vaccines, we typically have who it's recommended for and in whom is it contraindicated. So for instance, the MMR vaccine is contraindicated in pregnant women, it's contraindicated in people with immunosuppressive conditions, it's contraindicated in people who are taking corticosteroid medicines because the live virus in the vaccine, even though it's a weakened virus, might be dangerous for those populations. So what I suggest to people who have medical conditions or concerns is that they talk with their clinician, their doctor or their nurse about their own unique circumstance and what's the best thing for them. I think many people have heard rumors about vaccines and their safety, and it's really important to say that there's no link between the MMR vaccine and autism. There's no link between the preservative thimerosal and autism or neurologic development problems. Some of the concerns people had about those links were based on data that has not panned out to be the case. But it's really important for people who think that they have a genetic problem or they are aware of a medical condition their child has or that they have to talk that over with their clinician. I can say as a physician and as a public health expert that the vaccines we're using are very safe and effective, but it's always important to get your questions answered and have a doctor or nurse that you can raise your own questions with.
There's actually another good question here, which is what role, if any, should employers play in vaccination?
You know, we think that employers have a lot of potential to improve health in the workplace and health among their employees. Of course, the most valuable thing right now is that employers often pay for health insurance, and good news right now is that based on the Affordable Care Act, health insurance has to cover preventive services, including vaccines, without co-pays or deductibles for insured people, as long as they get the vaccine from an in-network provider. Now for children, we've had the Vaccine for Children program for more than 20 years now, and that gives low-income and uninsured children access to free vaccines from a VFC provider. It's a really simple system, and it's really made the difference in economic disparities in vaccination in children. But a lot of adults haven't had good insurance, and now we're pleased that insurance really needs to cover these preventive services that can save dollars for the workplace and can also keep the workers healthy. We do recommend all adults get a flu vaccine every year. We recommend pregnant women get a flu vaccine and also get a tetanus, diphtheria, acellular pertussis, or whooping cough vaccine every time they're pregnant, late in pregnancy, to protect the baby. So there's a lot of vaccines now recommended for adults, and we hope employers will, a lot of employers have workplace newsletters. We hope they'll remind people about these vaccines and how to get them. Many workplaces actually offer flu vaccine on site, which is actually valued by the employees. So we're seeing a lot of adults do get vaccinated in the workplace, particularly against flu, and so we hope employers will be part of the strong partnership.
That's terrific. We just have a few minutes left,
Sure.
and I want to get to this last question. You referred to it earlier, but some lawmakers have said that undocumented immigrants are bringing measles into the U.S. Is there evidence to support the claim?
No, we don't have evidence to support that. I know that immigration is a complicated issue and people have strong feelings about it. One thing to say is that the region of the Americas was the first region to actually eliminate measles, eliminate native measles. Before 2000, there were lots of importations of measles virus from South America and Central America, but what happened was we actually saw great campaigns against measles and rubella in the Americas, and in 2004 the region of the Americas was certified as measles-free, meaning that there wasn't circulation of the virus for more than 12 months. That takes a lot of work to sustain, and right now Brazil is having some challenges controlling an outbreak there. But in general, we aren't seeing measles imported from Latin America. In fact, this outbreak associated with the Disney park, the U.S. exported measles virus to Mexico. So we see the virus, unfortunately, going the other direction. It's really important for people in every region to have access to vaccines, and through really great efforts of the Pan American Health Organization, wonderful efforts of the Gavi Alliance, we're seeing access to vaccines all around the world now.
Terrific. We've got a minute if there's one or two more slides that we can get through.
Yeah, I want to just remind journalists that you hear a lot about the people that aren't getting vaccinated, but I think it's really important to realize vaccination is a social norm. Less than 1% of toddlers in the United States have received no vaccines at all. In survey after survey, parents say getting their children vaccinated is the right thing to do. And so I think for journalists, it's important not to stress the extreme circumstance, not to really give equal time to that very rare side of the story. And so we think it's important, for you as journalists to cover the stories, not necessarily the numbers. I know people get frustrated that our numbers bounce around a lot. It's because there's active investigations going on. But the people behind these diseases, the people behind the control measures, the people in the doctor's offices dealing with the idea that measles virus lasts in the air for 2 hours after the child with measles has left. They're pretty intense stories to cover. We hope that journalists will be able to find the facts and separate them from the fiction and the myths. And I do recommend CDC's website, cdc.gov/vaccines, as a great source for information.
Perfect. We're going to end on that note. Thank you so much. Great advice for journalists. Dr. Anne Schuchat, Director of the National Center for Immunization and Respiratory Disease at the CDC, and thanks to Bayer, who provided funding for today's program. You'll find the schedule of upcoming webinars at our website, nationalpress.org. You also can sign up for the newsletter, use the donate button on the homepage, and thank you for joining us in the Evelyn Y. Davis studios at the National Press Foundation, where we are making good journalists better. Thank you.